Good morning, everybody. We're going to get started. My name is Sam Shemy. It's a pleasure for me to moderate this particular session. There have been, in our country, a few inflection points of changes of healthcare culture. The first one clearly was medical assistance in dying and what that means and how that impacts end-of-life care and organ donation as well, as we heard yesterday. But the second inflection point is a move towards opt-out presumed consent legislation in Nova Scotia. For me, it's a pleasure to welcome Phil Walton here, who is from Wales, was originally effectively a donor coordinator, what they call specialist nurses in organ donation, and involved through the organization in the UK to in fact be instrumental in the development and implementation of presumed consent in Wales, and now the implementation, operational planning of presumed consent in the United Kingdom. So he is a world expert in how this impacts organ donation, transplantation, and discussions at the bedside in intensive care units. So it's my pleasure to welcome Phil to the stage.
Okay, good morning. Thank you to the organisers for inviting me, and thank you to those of you in the audience who had a particularly difficult night last night and have still made it up early this morning. It's a fear of mine that I was going to be presenting to an empty room, so thank you very much. So 2 little bits of housekeeping to start with. Sam just said that we talk about specialist nurses for organ donation in the UK. That's abbreviated to SNOD. So for those of you that want to have a giggle now and get that out of the way, do it, because it's distracting. And secondly, you talk about presumed consent in Canada. I'm going to end up tripping myself up if I talk about presumed consent all the way through. So we call it deemed consent. So for those of you who are not familiar with the setup in the UK, obviously you're probably aware where the UK is, but we've got different countries that have their own governments, and legislation works a little bit differently in the UK. So from a deemed consent perspective, Wales went live with deemed consent on the 1st of December 2015, and I was the operational leader in charge of making that happen. On the 1st of July 2019, Jersey, which is a small channel island off the southwest of England, went live with deemed consent legislation. They were super supportive, super happy to give us only 6 weeks' notice that they were going to change their law. So we had to operationalise that super quick. England are due to go live in spring 2020, Scotland in autumn 2020, and then we've got the Isle of Man, Guernsey, due to go live at some point, and then Northern Ireland are not going to change their legislation. So lots for us to do, and the complicating factor is that we have one organ procurement organisation in the UK who will cover all of these legislations. So by the end of it, we've got specialist nurses for organ donation covering 7 different legislations. So there is a complication and a complexity involved in this. So I'm going to talk a little bit about Wales first, give you some background about what we did and how some of the lessons that we've learned. So we went live on the 1st of December 2015. We had an 18-month kind of media campaign to support that. The programme itself ran for 2 years, and it was a £2 million campaign. Public advertising was rife, whether that was TV, radio, buses, billboards, anything that stood still was posted and covered in our promotional work. The thing that we have in the UK is a UK-wide organ donation register. So wherever you live in the UK, you can go online, you can register your decision to be an organ donor, one way or the other. Well, pre-2015, it was just you could register it one way, you could opt in. We have partner feeds through major multi-chain companies and the driving licence agency that will also feed into the organ donor register. But from 2015, we needed to be able to provide an opt-out functionality to that. And that comes with quite a lot of work in the background from our IT guys. That opt-out functionality was available wherever you lived. It wasn't just particular to Wales. So like every good organisation that's full of regulation, we have policies, procedures, regulations, management process descriptions. We have over 500 in NHS blood and transplant that needed to be reviewed, plus or minus being changed to reflect the new legislation. So that was a a very dull piece of work, but completely necessary to do, and I'm delighted that it's come round again for when England go live, and that's my job. So there's only 2 regional teams. We've got 12 regional teams in the UK, but 2 that cover the Welsh country. So we had to do some training and education with those 2 teams to focus on the change of language that reflected the law and introduced it to donor-family conversations. In essence, what that looked like was a code of practice was provided for us. We read the theory of the legislation, and then we did a little bit of practice. It was looking back on it, the education package was suboptimal, I would say. And in the background through all of this, the public debate was that we had a lot of ethical questions. Organ donation experts coming out saying this is immoral, and even our own Archbishop of Wales coming out saying that the legislation was wrong. Much of it centred around the concept of, is organ donation a gift if it comes from deemed consent? So what does this legislation look like in Wales? This is part of the promotional campaign, trying to make it as simple as possible. You've got 3 options. If you want to be a donor, you can opt in. You can do that online via the driving licence agency or one of our partner feeds. Or if you want to be a donor but can't be bothered to do anything, then don't do anything. And we'll presume that you want to be that donor. If you don't want to be a donor, go online and opt out. You can only opt out online or via the telephone, so it's an immediate registration. There's no lag time with postal delivery or anything like that. But the legislation does have some safeguards in it. It's not applicable to absolutely everybody in Wales. So you have to live and die in Wales for this legislation to apply to you. You have to be over the age of 18. You have to be ordinarily resident in that country. So you have to be there for settled purposes. Okay, so people like armed forces, prisoners, they're not there for settled purposes. They are there not by choice necessarily. You have to have mental capacity to understand the notion of the legislation and the impact that will have in the event that you would die in circumstances that allow you to be an organ donor. And crucially, if you've made a decision about organ donation, whether that's verbally expressed to your family or whether you've opted in on the organ donor register, deemed consent doesn't apply because you've made a decision, and that's first person. So we were really lucky. We were approached by Bangor University just before the legislation went live in 2015, and I think Amy Sati, I think some of this work here complements what you're doing as well. So if you've not already seen it, then I think we can probably share some of that. But the researchers went and spoke to donor families who went through the organ donation system, whether they donated or not, and they were even able to access some families that said no to organ donation and try and get under the skin of what their feelings, perceptions, perspectives on the organ donation system with deemed consent was. And we had some really interesting insights around it. So the government were very clear around saying that if you do nothing, that's a decision to be a donor. But when we interviewed families, they were like, doing nothing, it might be a choice, but it's not a decision. You have to be very clear about that. So that's a lesson that we've taken forward into England. For the specialist nurses in organ donation, bringing up legislation with the family straight away is just the biggest turn-off. You get a no for organ donation straight away, and you have to think about how you're going to deliver that conversation. And there's a plug for a little while later on. I'm going to be talking about donation conversations then. The implementation of this legislation meant that we now have 13 consent and refusal pathways for a specialist nurse to navigate their way through. And it can change depending on the picture that you've got in front of you with the family that are there. So one of the big impacts from this was directed at the government themselves in terms of their marketing campaign. They said, you told individuals, you told citizens what they needed to do, but you didn't tell the family how they should support it. And that was a really important own goal that the government made. And the media campaign around that was completely unmemorable, whichever. So this is the work that came out of the Bangor University study. We've got kind of 8 papers out there now, everything from the family attitudes to deemed consent through to the tone of media through that period. Really interesting read, and we can share that if anybody's interested at all. But the advertising campaign wasn't memorable, and the government quickly changed their attitude. Okay, so does it work? Does legislation work? So here we've got, on the blue line, we've got the UK consent rate over from 2009 to 2019. Blue is the UK, red is Wales. Now, Wales is a population of about 3 million people. The donor population is very, very small, so we often see artifact on these types of line graphs. So that's not abnormal for us. But the legislation came in 2015-16, and we've been on the rise ever since. We ended 2018-19 with a 78.9% combined consent rate for DVD and DCD. That's pretty impressive from where we started down in the 50s. Our very clever colleagues in statistics, who are far more capable of articulating what I'm about to show you, developed a sequential study plot of the impact of legislation change on consent rates. So here, essentially, we are looking at a 10% statistical difference for an increase in consent rates. If you hit the top blue line, so if you go into the top blue area, there's a 10% increase in consent rates in Wales compared to England. If you fall into the lower blue, then it's a 10% decrease. And if you're in the middle, in no man's land, no difference. So this was run over consecutive quarters for 12 quarters. The first 2 or 3, not an awful lot happened. But as we move forward, if you look on the left-hand side, we've got DVD consent rates at quarter 11 hit a statistically significant increase in consent rate for DVD, which was, for us, just positive feedback from our point of view in terms of the implementation program. We didn't see the same in DCD, and I think this is the same all over the world, that DCD consent rates lag behind DVD for a number of multifaceted reasons, and we're still working around that. But at quarter 9, we did see a kick in the tail, so we're just going to be monitoring that informally to see where that gets to, and that will inform measurements in in England. So spring 2020 is when we go live in England, and we're delighted that much of the groundwork has already been done. We've got so much more intelligence around how deemed consent works, which is great. But while we had to train 15 specialist nurses for organ donation in Wales, we've got 300 to train in England. So the training model looks a lot different. It's very modular-based, it's competency-based as well. And there is an issue around consistency of delivery in there. We've got much wider external engagement to cover, from everyone from professional bodies to faith groups. We'll talk about that again in a second. And the IT changes for Wales were very minimal, though it was like an add-on to our potential donor audit, which was fine for what it was, but actually we uncovered a whole load of problems around consistent reporting, which means if you're not measuring it or reporting on it properly, the outcomes are a bit shocking. So we're spending an awful lot of time, money and effort making sure that our potential donor audit looks how it should, and what you put in is what you need to get out. And again, the consistency of 300 people interpreting medical notes in a very different way will cause a problem. One thing we don't have in Wales, we have a very white population in Wales. We've got no intelligence at all about whether deemed consent complements, works with Black and Asian minority ethnic groups. So we need to learn quickly on the move in England, because we have a much more diverse population in that country, and we have to respond, react and adapt very, very quickly in those areas. And again, each country or territory in the UK is going to have its own law, so that provides its complexities around how we're going to deliver that and making sure that the risks are mitigated as best as possible, so that we're not unlawfully acting in a certain country because we're confused as to where we are. This is kind of our Bible. Our regulator in the UK is the Human Tissue Authority, and this is our go-to document. They've provided a code of practice for deemed consent. They did that for Wales. That's available to share. We can do that, and they're in the final throes of finalising the English document now. One of the best things around that is that we've had a seat at the table. So the Human Tissue Authority read the law. It's written in legal speak, so very few people understand it, and they translate it into English. But actually the practical application from that comes from the experts, which are NHS Blood and Transplant. So the English law is very much driven by, or fronted by, these two young people. So Max and Kira. Max was 11 years old. He was waiting for a heart transplant. And we had a documentary program that followed him around. He was dying, and the program, he was very clear, very mature in the way that he spoke, saying, I'm going to be giving my parents my final hug at some point soon. Fortunately for him, but sadly for Kira, she died in a car accident and his family consented to donation, and he received the heart. The media campaign around that pushed forward his name, and it was going to be referred to as Max's Law. But the mature, beautiful young boy that he is said, it can't be Max's Law, it's got to be Max and Kira's Law. So the legislation is referred to as Max and Kira's Law informally, and I think that speaks to the population about how important this piece of legislation is. So what's changing in England? So I showed you what the Welsh legislation looks like, and it's, it's very straightforward. And gratefully, from my perspective, England have cheated, and they've changed the name of on the exam paper, but everything else is the same. All the vulnerabilities, the vulnerable groups are all exactly the same. There's some nuances, some slight differences, but on the whole, it only applies to over 18s, people who have capacity, people who are ordinarily resident, and those who have not made a donation decision. So it's very straightforward, very helpful from our perspective that it's very, very similar. So professional bodies and engagement. So we've got organisations that have touch points with our critical care patients, but not every day working with donation. But they have their questions and concerns and fears and actual positives that they can offer, advice that they can offer to us, and we have to listen. And I think that's one of the most important things that we've done is we've gone out to all of our professional bodies and societies, shown them what we've got already, been open and transparent, and allowed them to feed back. They've had a seat at the table with a consultation document that's going to be our code of practice, our little Bible. So I think they are feeling very well engaged and informed, but crucially involved in this process. Similarly, we've had to be collaborative with Parliament, with patient groups, with the NHS in general. Faith, I said earlier on that we've got no intelligence about faith culture, Black, Asian, minority ethnic groups at all. So to spend time working with each and every one of those has been really important, particularly with the Board of Deputies for British Jews, who just wanted a simple document that outlined what happens to a patient from admission to donation. So we wrote that, and we provided that for them, and they've spread that into their community, and actually their community is much more supportive of donation and less suspicious than they had been previously. And that draws onto the faith declaration that we went through last year, where we engaged with each and every major faith group in the UK and sought their support for organ donation. Does it fit within their culture, within their belief system? And there is not a single faith or belief culture in the UK that has said that they do not support organ donation. So we created these organ donor cards that are relevant to their own faiths and beliefs, and that message is getting out there. And when you sign on to the organ donor register, you have a question that says, would you like NHS staff to speak to my family about anyone else appropriate about how organ donation can go ahead in line with my faiths and beliefs. So end-of-life rituals that are important to that individual. We're kind of not just covering it off, we're delivering it. So in terms of projections for deceased donations and transplantation, this is what we've looked like over the last 10 or 15 years, donors in orange, transplants in blue, all going up, everyone's all very happy and swimming, but what is donation going to look like after deemed consent legislation? So I'm not going to be so rude as to say we've plucked numbers out of the air, but we've used an educated guess in terms of what the response and outcomes have been in Wales and applied that slightly to England. And again, the numbers are still going up. But at the end of it, so last year we had 1,600 donors in the UK, and in 5 years' time we may well have 1,860. It's possible. But what that means is 260 more donors and 990 more transplants. And that's why we do the job, really, because we're saving lives, and that's the important part for all of us. So I guess some reflections and things to think about from a Canadian point of view is get your measures right, understand what you're measuring. It was so unhelpful to us when people came out from a political standpoint and said, organ donation is going to deliver 500 more transplants, or, we're going to get 20, 30, 40 more donors. We still live with that legacy in Wales now because the legislation affects the donor family conversation. It affects consent. Now, by rights, you should think that if you get more consent, you get more donors, you get more transplants, but it doesn't work in a linear fashion like that. So be careful where you focus in the short term. In the spirit of true collaboration, get the right people around the table. We would never have got, so this bill that went through Parliament, that's now an act, it was a private member's bill. Private members' bills never, ever come to anything in the UK. They're just squashed. This went through Parliament, went through the House of Commons, it went through the House of Lords, and came back again with barely an amendment to it. There was cross-party support, but if it wasn't for NHS Blood and Transplant being at the table and collaborating with the Health Department, the questions and fears of politicians would not have been allayed. We had experts around the table helping our politicians understand the practical application of organ donation, because while we all know we're all experts here, the politicians aren't, and they need that support. And communications, I think when we talk about communications, we think about the external flow of communication, what we're going to tell the public, how we're going to message it, what are the key messages that they need to understand, and how are they going to, what are we going to ask them to do, what is their call to action. And that is all very important. But I think equally important but easily overlooked is the internal communications. Your staff are your ambassadors for this legislation, and they're ambassadors for organ donation in general. And if they don't know what's happening, if they feel that they are in a vacuum, they will get scared, they will have fears, worries, complaints, concerns, maybe even switch off, maybe even be a blocker. Okay, and you don't want that. So, thank you very much.
We're going to continue with our original plan. Steve Bede from Nova Scotia, longtime medical leader in anesthesia, critical care, and organ donation. I just want to acknowledge, because Phil has been really helpful to this evolving Nova Scotia experience and very benevolent with his time and his expertise, both remotely and in person. So,
good morning. I'm certainly aware of the fact that we've got a lot to do this morning, so I'm going to fly right into this. Thank you very much for the opportunity to talk about a topic that has garnered a lot more attention than I thought it might. We all understand that the reason we're trying to support this is because we need more donors, and that is not lost on our political mentors. I've been involved with this conversation for a long time, but some years ago I was blindsided by this news report where our Minister of Health, who very sincerely is supporting increased donation, announced to the world that Nova Scotia was considering presumed consent. I had absolutely no idea they were thinking about that. That's an uncomfortable question to ask or to have to answer. But if you look at the date there, that was 2014. I've actually given several talks, one in Alberta, one in British Columbia, Transplant Atlantic, and I've been on both sides of the fence in presumed consent, opt-out. Our political leadership were very supportive of donation. They sincerely thought this should be the right thing to do. And this is what led to Minister Glevin's comments to the media. We all knew in a general sense that you may get higher donation rates in an opt-out system. Some have reported 30%, but as Phil pointed out, getting tied to a number is dangerous. The real concern was that you need to change the system, not just the law. And our concern is that if we're going that way, teasing out the effect of the law is a challenge. So let's talk about our journey. As I alluded, in April, the Minister of Health announces this. Nothing happens except to say, thank you for your interest, but we're not going there. But in August of 2018, we got a phone call from the Premier himself saying, we want to talk about this. When the Premier phones, you go. And that conversation led to legislation, setting up committees, getting the money to do it, and a Health Canada opportunity, which we'll talk about in a bit more detail. So in the early days, as I alluded to, we had a provincial government who was honestly committed to increasing donation. And for many people who don't know the topic particularly well, if they're supportive of it in principle, it seems like opt-out or presumed consent is just an absolute common sense thing to do. So they said that. Our challenge was that Nova Scotia is a tiny province, but in spite of that, we had basically, over the last decade, more or less the best donation rates in the country. But that isn't the way it is recently. We started to falter, so we were looking at trying to reboot our program in around 17 and 18, and then we get a phone call, and when the Premier went to meet, we went to meet with them. All the important people were in the room, and we had a very frank, lengthy, it was 2.5-hour conversation with the Premier about this. And there was several messages. We had been a leader, but we're starting to fall behind, and other provinces that have invested in their system are doing much better. This may increase donation, but a law is just a bunch of words on a piece of paper. But we did think Nova Scotia, for a variety of reasons, might be a good place to innovate. Our argument was, if you're going to do this, we really need to reboot the entire system. And we understood that this is a transformational change. So if we're going to do this, we're under no illusions that it's going to be easy. But we're prepared to see what we can do. And so we started working on it. And from that initial meeting right through into February or March, there was a variety of conversations around tweaking the legislation so that it could be actually brought forward. And we got a commitment from the Premier that we would basically be able to completely reboot the donation program. And when that opportunity presented itself, we said tissue bank and transplant also need that support to reboot, and the government confirmed that. The specific things within the donation program we're talking about are increasing the number of coordinators and changing their role, establishing donation physicians, a province-wide DCD in conjunction with MOTP, which we don't have now, increasing QA support, an education lead for the province, family support liaison, IT support, database, we've had none of that historically, and revise our chart audit process. So if I have to sort of sign on to a law, and this is what comes with it, I consider that a major win. So we were all in to try and do what we could do. But it's a lot of work. After that commitment, reviewing the legislative change, we developed detailed plans to reboot donation, transplant, and RTB. Legislation was introduced. It got through first, second, and third readings. A bill that costs money that gets unanimous consent is almost unheard of, I think, but that's what happened. I was very surprised by the national media. I knew there'd be a little blip. I had no idea that there would be as much as there was. So what are the key things? Well, we've gone from an opt-in to opt-out. We will have mandatory referral. We've clarified the consent process around the donation circumstance. We now have specific reporting of donation metrics to leadership of the hospital systems, which we didn't have before. We're allowing interaction between donor families and recipients, and we've clarified the death determination, all as part of the law. We talk about it as a presumed consent opt-out, but there's a bunch of other things in there as well. So how have we done it? Well, we set up a steering committee with the Nova Scotia Health Authority leadership as well as the Department of Health. And basically, we have been meeting very regularly, and there's a whole bunch of subgroups that have been trying to oversee the implementation. And to their credit and to my frustration, the government partners are working extremely hard and very, very fast by government standards and very, very slow by ICU standards. But that's our reality. I don't understand their world. It's frustrating and it's slow, but they are really, really working hard and working quickly through a government lens. But there's a lot to be done. We've been meeting formally every month, with subcommittees meeting more regularly, and there's been a variety of major issues that have come forward that we're still working through, including our implementation strategy and evaluation, the registry that we committed to developing, and our communication strategy, which is crucially important but still a work in progress. The other thing we did was set up a committee to actually operationalize this new law. So we had that oversight connection with Department of Health, but we also have to practically develop a system at the bedside that's going to work. So we've been working with RTB, MOTP, NSHA partners, and meeting basically every 2 weeks to develop a bunch of things, and a variety of challenges have presented themselves, including IT challenges. So if there's really talented, committed people to the donation world who would love to come to a really great province, we'd take your resume. And I'm not kidding, actually. I'm really not. So what else have we been doing? Well, we finished program proposals from April through August. And in June 19, we were hit with a wonderful opportunity, and that was relatively out of the blue, the opportunity to get funding through the Health Canada projects, which many in this room would be aware of. The timeline to put something together was just ridiculously compressed. A letter of intent within a few days, proposal within 2 days, and we've settled on doing 3 big projects. And that's a close look at donation performance metrics, sort of pre, now, and in the future around this whole thing. a detailed look at presumed consent around the world, including ethics and legal review. And what the most important part, in my opinion, is we're going to do a really deep dive on knowledge and attitudes around donation and presumed consent in the Nova Scotia population, especially focusing on marginalized populations. And as people know, this work has been proceeding in a variety of places across the country. Our project is with partners with CBS, CDTRP, Transplant Quebec, and NSHA, and we've been working pretty hard to try and get all of this done. And where we are right now is essentially we've got our steering committee set up. Activity 1, 2, and 3 are fleshed out a bit more detail. We've got our terms of reference. We're working very closely on finalizing our budget. We've recruited a bunch of local people within the research community in Nova Scotia. We've had our face-to-face in Banff to highlight some of this stuff, and now we're getting down to the nuts and bolts of actually doing that work. So what do we have to do immediately? We need to get our communications plan developed and implemented. Our IT needs have been identified as a challenge, but we aren't quite solving that problem yet, but there's hope on the horizon for that. Our opt-out registry, which we committed to, there's contractual issues with a provider in Nova Scotia that have limited our options, but it looks like that's getting settled. Jennifer Hancock is committed to lead our education role for the province, which is obviously huge. We need to recruit some good people to Nova Scotia, and then the whole Health Canada thing. And I'm going to leave it at that. Just the summary, the take-home message is that we understand this is a huge opportunity. I've been surprised by the amount of work that needs to be done. Maybe we shouldn't have been, but we're on board to do it. Thank you.